everyone. My name is Lily. I'm the office manager at Community Health Resource Center. Thank you for joining today's community outreach presentation, Weight Loss Medications and Your Heart, What You Should Know and What's Next, sponsored by CPMC's Kanbar Cardiac Care Center. Today, we're fortunate to have CPMC Director of Advanced Organ Therapies Metabolic Health Program, Dr. Nisha Patel, here with us to discuss the connection between GLP-1 agonist medications and heart health. Before we get started, I'd like to share a few words about the Kanbar Cardiac Care Center. It was originally founded in 2002 at the CPMC Pacific Heights campus and relaunched at the CPMC Van Ness campus in 2022. The center was formed through the generous contributions of the late Maurice Kanbar, who was an inventor, innovator, entrepreneur, but more importantly, a philanthropist. The Kanbar Cardiac Care Center is one of the highest ranking cardiac health facilities in California and offers an array of cardiac services and specialists who use advanced technologies to diagnose and treat patients with heart disease. Its nationally recognized physicians, surgeons, and clinicians are committed to providing excellent, personalized care in a contemporary and welcoming setting. And just as a reminder, the information provided in today's presentation is for educational purposes only and is not a substitute for professional medical advice. I'd now like to pass it along to Dr. Patel to introduce herself and dive into the presentation.
Awesome. Let me just share my screen. Well, I'm so excited to be here today to talk about one of my favorite topics. It's something that I could literally talk about all day and every day. So I hope that each of you walk away with a tangible piece of education to improve your lives. And thank you so much for being here. So like Lily said, I'm Dr. Nisha Patel, and I have the privilege of running our obesity medicine and metabolic health program here in our advanced organ therapies department at CPMC. And today, I'm just going to minimize that. Oops. Today, I'm going to actually talk to you about the critical link between obesity and heart health. And we're going to review effective obesity treatment strategies, including some lifestyle factors and medications. The focus of the talk will be on medications, but I do want everyone to understand that lifestyle factors are the foundation of care. I want to empower you all with knowledge and practical tools to have meaningful conversations about treatment and cardiovascular wellness with your own providers. So I always start off with a quote from a patient. So one of my patients said to me recently, is this what it feels? Is this what it's like to feel normal? And that person wasn't the only patient that I've ever had say that to me. I've had actually many patients say this to me. And they really are saying this in reference to just the relief or freeing effect of these medications, such as Wegovy and Zepbound and Mounjaro and Ozempic, which I'll go into, and how it helps them really focus in and eat healthier and help their lifestyle. And so it really can be life-changing for patients when they have the appropriate tools and treatment to help improve their health. And I always start off by saying that if you take nothing away from this presentation, we really want to remember the following two essential points. So we don't want to contribute to weight stigma, and we always want to use people first language. There are certain terms that we definitely try not to use, really not describing an individual based on their disease. We don't say diabetes people, but we often say obese people. But really, remember, this is a chronic disease. And we really should emphasize that it's, people with obesity or people struggling with their weight. We really want to use terms that don't contribute to weight stigma. And I really want to emphasize that, obesity doesn't happen because because it's a lack of motivation or a failure of willpower. There's actually very strong forces at play. Obesity happens because your body's signals for hunger and fullness just aren't working properly. And that's happening without a lot of people even knowing it's happening. And the brain really plays a central role in that. So I know these are very busy pictures, but it's just to really help people understand just how complex this is. So what is obesity? It's a medical condition in which an individual that carries excess body fat And this excess body fat accumulates to the extent that it may have a negative impact on their health. It could reduce their life expectancy and create health problems. We know that obesity develops because it's a combination of our genes and biology and environmental factors that contribute. Most diseases have contribution from both. It's not just one or the other always. And your genes do play a big role in body weight. When you look at studies from twins, they often have the same genetics, especially identical twins. And we've seen that the differences in body size are often passed down in families. In fact, researchers believe that 40 to 70% of a person's body size may be influenced by their genes. So this means that while lifestyle changes like diet and exercise are important, again, I'm going to emphasize they are important, but we do know that genetics can also have a strong impact on whether someone gains or weight or develops obesity down the line. And your brain is, I always tell patients, your brain is the master regulator of body fat levels. You know, when we talk about weight loss, we're really referring to improving body fat levels, right? But your brain is incredibly good at trying to counteract weight loss. And so it is, I consider it the master regulator of body weight or body fat levels. And so I always tell patients too that losing weight is hard, but maintaining that weight loss in the long term is harder. And oftentimes the conversations again center around, lack of willpower, lack of motivation. Many patients come to me and say, I've lost the weight, but over time I ended up gaining it back and I should have just tried harder or the things that were working for me to lose the weight stopped working for me to actually keep the weight off. And eventually I regained it. And I often describe and talk to them about the tug of war between weight loss and weight gain, which is strongly influenced by our hunger and satiety hormones and also that underlying biology. And why do we have these pathways that, counteract weight loss or make it harder to lose weight? We actually think that at least for our ancestors, these were survival mechanisms to prevent malnutrition and starvation. But in our current environment, they are not that protective. We live in a very challenging environment, right? We are not sleeping as much. We are pretty stressed out. I always joke and say convenience is killing us, but it is also very nice to have some of those conveniences. We don't even have to go to the grocery store anymore. We can actually order groceries. We spend more time seated. And then our food environment is very challenging to navigate. We are surrounded by food that is very tasty and very easy to overconsume and very pleasing to our brains, to those hunger and satiety pathways. We know that most people that have struggled with their weight or people with obesity on average make at least 7 serious attempts at weight loss during adulthood. And in structured weight loss programs at the 5-year marks, after 5 years of participating, and this is without medications, by the way, I should say, this is mostly lifestyle factors, at least 80% of individuals regained some of their weight, and then 50% or more actually regained weight at 2 years post-program. So what are the health consequences of having obesity? So I want people to understand that our adipose tissue, which is the medical term for fat tissue, it's just not sitting there and doing nothing. It's incredibly active and it affects your health. And we could argue that it's actually the largest endocrine organ that many people have because it makes hormones, it makes all these factors. And what they're doing is they're traveling to different parts of your body and exerting, positive or negative effects. And so it is really problematic. And it's not so much about just how much body fat somebody has, it's about also where they store it. So we know that individuals that store more of their body fat in their central abdomen, especially around their internal organs, which we call visceral fat. Right here, you can see it's in between the intestines and internal organs. This particular type of fat is pretty inflammatory. It makes a lot of those hormones. It's communicating with those internal organs. And it's creating problems for people. It can increase their risk of diabetes. It can increase their risk of heart disease. We have actually the same kind of fat, this visceral type of fat that sits around our heart. And that can create problems like heart disease, heart failure with preserved ejection fraction. And so really improving total body fat percentage can help improve this visceral fat. I joke and I say, I wish there was a way to target belly fat, but there's not. We really do have to work on improving our body composition and improving our body fat levels. And we should understand that, obesity does impact every single organ system. And the focus of this talk is, of course, heart health and how we can improve our heart health by using evidence-based treatments, but understanding that, there's increased risk of cancer, diabetes, kidney failure, sleep apnea that also can be seen. So what is the link between obesity and heart disease? So the first thing to understand is the heart disease is the #1 cause of death in people with obesity, and obesity is an independent risk factor for cardiovascular disease. It increases the risk of a specific type of cardiovascular disease called coronary heart disease. That's when you have blockages in your artery by 50%, even without other medical or metabolic diseases like diabetes or metabolic associated liver disease. Over 80% of patients with coronary heart disease, they have overweight or obesity. And we know that obesity-related cardiovascular deaths have actually tripled from 1999 to 2020. And so there really is this urgent call to action and need for effective weight management in patients with obesity and heart disease. And we know that even when you treat other risk factors, when you try to reduce risk of heart disease by modifying blood pressure, cholesterol, blood glucose, people with obesity still carry that residual risk. They still have a higher risk, even though you're trying to do everything you can. And the more severe the obesity is, the higher the risk. So for example, on the lines below, we talk about risk of developing another recurrent cardiac event, I should say, after having a heart attack. And the more severe somebody's obesity is, the higher the risk of developing another heart attack after already having one. Let's talk a little bit about treatment. So I want to always emphasize that treatment has to be thought of as individualized and comprehensive. We can't really prescribe a one-size-fits-all. And I tell patients that treatment isn't about just achieving a number on the scale. It's about really leaning into how you feel, improving their health, improving their quality of life, and more importantly, also improving their body composition. Yes, we do look at the number on the scale. Weight is a metric that we track, but I love to ask patients, like, tell me how you feel. Like, what are you able to do now that you're at a healthier weight? What's your blood pressure doing? What's your blood glucose doing? Like, those are all things that are really worth tracking and taking note of, because at the end of the day, that's what it's about. And I just love when people tell me, like, I wasn't able to do like a certain activity. I couldn't go hiking, or I couldn't, train for this triathlon, but now I can actually do it because I feel better. And we understand that the treatment goals is not just normalizing body mass index or, trying to, again, achieve a certain number that's a certain BMI, I should say. So a lot of people are familiar with BMI. It's a calculation that's made based on weight in kilograms over height in meters squared. And the thing with BMI is that it's pretty helpful at a population level. So when you're looking at like the entire population, if you're trying to kind of understand rates of a disease like obesity, it can really help us understand like what those rates are kind of nationally, for example, in America. However, at an individual level, so you as an individual, it really doesn't tell me anything like about your health. It doesn't tell me, how is your BMI affecting your health? Do you have other diseases like diabetes, heart disease? Where are you storing the body fat? So this word body composition that I keep throwing out there is important to really understand as a metric. So whenever people lose weight, they don't just lose body fat, they also lose lean muscle mass. And that comes with any form of weight loss. It doesn't matter if it's lifestyle or medications or bariatric surgery. And I always tell patients that what I like to see is as much improvement in body fat as they can by trying and keeping their lean muscle mass as stable as possible or not losing as much. Because when you have improved your body fat, but kept your lean mass or lean muscle mass the same, you've improved your body composition. And muscle is also what we call a metabolic organ. Muscle is really important to try. Muscle function and strength and mass is really important to try to hang on to, because it's got a lot of benefit, especially as people get older, especially as people get sicker. So we want to improve that body composition. But I have this graph up here, this picture up here, just to really help people understand that even in our medical guidelines, there's been a call to move beyond just targeting a BMI or targeting a number when it comes to treating obesity. In my practice, we are lucky we have an in-body scan. This is a specific type of machine. It does kind of look like a scale, but it actually gives us a lot more information. I use it to actually track body fat loss in my patients. So not only do we look at total body fat loss, we also look at that visceral fat level that I was talking about earlier. We do also look at their skeletal muscle mass, and we really try to track that. And it's been really great. It's been a wonderful tool for me because I can have these meaningful conversations with patients about, hey, like you are losing body fat, but hey, you're also losing lean muscle mass. And then, they work on their nutrition and their fitness for 3 months, and then they come back and we can actually see the fruits of their labor when they're actually still retaining a lot of their lean mass and lost further more body fat comparatively. So as far as treatment, we do have different options for treatment. I don't want anyone to think it's just GLP-1, although those are really wonderful tools. We do know that lifestyle modifications have a pretty modest benefit with weight loss, but when coupled with medications, you can really start seeing, weight loss in the 10, 15, 20, 25% of total body weight. Bariatric surgery is up there at 30+% of total body weight. Specifically, the gastric sleeve procedure is what we often still do. There are others, but I won't talk about bariatric surgery. It's beyond the scope of this talk. And then we know one question that I always get from patients is like, how much weight should I lose? And I often tell them that, if somebody loses between 10 to 15% of their total body weight, they can really achieve some pretty significant improvements in their health, including diabetes, their lipids, arthritis, sleep apnea. It's when you are losing about 15 to 20% where you really start to see that reduction in cardiovascular disease risk. And I always say that our lifestyle is important, but again, it is really important. It's also crucial to understand that often and enough by itself, it's not, often by itself, it's not enough to really help people achieve the weight loss goals or body fat improvements that they need to improve their health. Now, I will say again, everyone's there's a lot of inter-individual variability. Some of my patients respond really more robustly to lifestyle factors, and that's great. They don't need medications for the time being, but I always explain that, there are tools because, again, going back to what I said earlier, losing weight is hard, but keeping it off in the long term is harder, so that they understand that those are tools available for them. This slide is not going to do justice to the importance of nutrition in weight management. But I do want to put it in here because I want to talk about lifestyle a little bit because it is a part of the treatment. But weight loss at the end of the day does require, in order to lose weight, you do have to eat fewer calories. But again, going back to what I said earlier, in our food environment, it is difficult. So not only does it matter how much you eat, it still matters what you eat, because you're going to be able to eat healthier with fewer calories if you're eating foods like lean proteins, fruits, vegetables, whole grains, beans, lentils, and cooking more at home. I always joke and I say, yes, in theory, somebody could create a calorie deficit with Oreos, but that's going to be really hard because it's super easy to overeat Oreos compared to foods like chicken and a salad or quinoa or vegetables. So, it's much harder to do it with a lot of the types of foods that are available. So that's why we still want to focus on what we're eating so that we can get quality nutrition at the end of the day as we're trying to lose weight. We do want to aim for at least 1.2 grams of kilograms of adjusted body weight for protein. So protein is important in weight management. We know that it can help, patients feel fuller. We know that it also can help patients with preserving that lean muscle mass, especially combined with strength training or resistance training, which I'll talk about a little bit later. Tracking food. So whenever patients are starting to work with me, I do ask them to track what they're eating for a little while. That does serve a couple of purposes. So number one, it helps us understand kind of what they're eating over the course of the week versus just like day to day, because I ask patients to think about their eating in the context of a week, over the course of a week. The reason I do that is because sometimes, Monday through Friday looks like this, and then Saturday and Sunday looks like this. Saturday and Sunday usually looks more liberal for people because they're out with family, friends, eating out, and we really want to try to keep as consistent of an eating schedule as possible. And number two, it helps them understand what they're eating too, because again, your brain is very good at trying to drive food intake, sometimes without you even knowing it's happening. An example of this would be like if you found yourself in the kitchen after dinner right before bedtime and you're like, how did I get here? I'm not even hungry. Just know that some patients have really strong what we call food noise that really lures them back kind of to eating more than they intend to. Adjusting diet carefully on GLP-1 medications can really help improve the tolerance that patients have to medications. So there are certain side effects that can be precipitated by certain dietary habits that people practice. For example, when patients, if they eat a really higher fat meal or if they eat something very greasy, let's say they're just on the road and they're like grabbing some food from a restaurant, it may not really go down that well if you're on a GLP-1 medication, which goes back to what I said earlier. When we eat foods that are healthier, those are better tolerated also on medications, and people tend to have less side effects too. And then I am always kind of a stickler for sugary drinks. Anything that's sugar sweetened, I'm like, hey, it's a low-hanging fruit. Let's try to work on improving that. So here, I just wanted to, again, I brought this up to emphasize that it is very easy to eat more calories than we think in our environment. And these are just some sample meals that I went to the website and took from their nutrition facts label. But you can see that it's very easy to eat close to 1,000 calories. And the seared ahi tuna salad from Cheesecake Factory very much so surprised me, because I'm like, that does not look like 1,000 calories, but there's got to be something about it. Maybe it's the dressing or other condiments that come with it that bring up the calorie intake. So let's talk about medications. So this class of medications, the GLP-1 receptor agonists, I'm sure that many of you, if not all of you, have heard that term. The scientific name for them are actually nutrient-stimulated hormone therapies. We call them NUSH therapies, but they're commonly known as GLP-1 receptor agonists. So who qualifies for treatment with medication? So don't shoot the messenger, but the FDA and many insurance companies, unfortunately, use BMI-based criteria. So the FDA approves medications for people with obesity with a BMI of greater than or equal to 30, or patients with a BMI greater than or equal to 27 if they have some sort of other complication like diabetes or heart failure or heart disease, hypertension, high cholesterol. And so these are the criteria that many insurance companies use to determine if patients can or cannot qualify. I'm going to just, I guess maybe this is a good place to talk about insurance briefly, but just to let you know that the insurance coverage for medications varies widely. Insurance can basically come up with their own criteria. It may not always fit in line with evidence-based guidelines, but at the end of the day, we're at their mercy, despite fighting back as much as we can. So if you're interested in medications, definitely check with your insurance and see what their criteria is, if they will tell you, and what the coverage would be like. So going a little further, I just want to emphasize, I use this slide because I want to emphasize that although we talk a lot about GLP-1 receptor agonist class of medications, there are other medications that we use for weight management, and they are still good tools. And sometimes in patients that can tolerate both, I actually combine a pill medication with a once-a-week injectable to help them, especially if they're at a weight loss plateau and we have to drive additional weight loss. But the class of medications I'm going to focus on is really over here. It's these are all the GLP-1 receptor agonist class of medications that we use for weight management. So that includes liraglutide, and I'll tell you what the brand names are in just a second, semaglutide, and then tirzepatide. So a couple of things to know on logistical considerations about medications. Again, going back to what I said earlier, every patient is unique. Average weight loss from a study is just an estimate. Actual results can vary significantly from person to person. Some people may see excellent results and there might be a small number that have little to no weight loss. And that's very, very frustrating. And I wish there was a way for us to predict who those people were. I joke and I say these fancy AI algorithms out there, they're going to have to come up with some sort of program where if we enter in these patient factors, maybe we can better understand, that patients might respond to this set of medications versus this one, but we're not quite there yet. If somebody does experience weight loss early in their treatment course, that usually indicates that they're going to have continued success, in my experience. Medication dosing needs to be tailored to the specific patient. We, don't always have to go up to the highest dose. And I tell my patients, hey, let's use the lowest dose that's working for you, that's effective for you, that we're minimizing your side effects so that you can tolerate the medication better. And then people with diabetes usually experience less weight loss. Medication costs and insurance coverage remain major challenges, unfortunately. So it's important to understand that your body actually makes this GLP-1 hormone, but in our body, it's broken down very quickly. It only lasts for 2 to 3 minutes, and only a fraction of it actually makes it to the brain, which, remember, I was talking to you about the brain and how it's the master regulator of body fat levels. And so pharmaceutical companies have designed medications that are GLP-1 receptor agonists that not only are active longer in your bloodstream, they reach higher levels in your bloodstream, and they overall work better. I have this picture up here because I want people to understand that there are GLP-1, the activity of GLP-1 receptor agonists is in different types of tissue. We think that it can influence immune cells, a part of your immune system, skeletal muscle, your pancreas, your kidneys. And so, when you talk about these medications, I always kind of joke and say, these are not just weight loss medications. These are what we call cardiometabolic medications, because they have an impact on all these different tissue types, especially our cardiovascular system. So there's a number of brand names that these medications are sold under. So on the, I guess your left over here, these are the brand names, Saxenda, Zepbound, and Wegovy, that the medications are sold under for weight management. And over here, Victoza, Ozempic, and Mounjaro are the brand names that the medications are sold under for the treatment of type 2 diabetes. They are exactly the same as their weight management counterpart. You can think of them as twin sisters. So for example, Zepbound and Mounjaro are both tirzepatide. They're once a week injectables. But because they have different brand names, the insurance doesn't usually think of them as interchangeable. So for example, if I prescribe to Mounjaro, which is used for diabetes, to somebody for weight management, insurance won't recognize that and they won't cover it. That's the same for Wegovy and Ozempic, although the dosing is a little bit different. The Wegovy dosing actually is a little bit higher for weight management than the diabetes dosing, but they're pretty similar. And then I wanted to also emphasize that, oftentimes in the news or on social media, we often talk about these once a week injectables up here. But the first GLP-1 receptor agonist that was actually approved for weight management was actually Saxenda, and that's liraglutide. I don't use this one as much because it is a daily injection and it doesn't yield as much weight loss as Zepbound or Wegovy. And so people don't really want to take an injection every day, but it is still a tool. And it technically was the first GLP-1 receptor agonist approved. And its counterpart in the diabetes world is Victoza. And that dosing is different. So usually dosing of these medications for weight management are a little bit higher than the dosing for diabetes. So what does the data show us about improvements in cardiovascular disease risk in patients with obesity? So we actually had and you're going to see some graphs and charts and all this. I will break it down for you because I know it can be a little bit busy, but we do have data for improving heart disease or cardiovascular disease outcomes in people with obesity, even without diabetes. So there's a lot of data actually out there for improvement in heart disease risk or cardiovascular disease risk in people with diabetes. That data has been published for years. But when we're actually starting to learn more and more about the health benefits in people without diabetes. And those trials are either recently published in the last several years or they're ongoing. So there was a big study that was published in 2023 called the SELECT trial, This particular study looked at Wegovy, or that semaglutide medication for weight management, in people that had both obesity, and they also had to have established, so they had to already have cardiovascular disease. It was a big study, over 17,000 participants in this study, and they were followed for almost 3.5 years. And what they actually saw in this study is that there was a reduction in cardiovascular risk in people that were on the semaglutide compared to placebo. So I know this looks a little strange, but you can see that there's this top line right here that says placebo, and this bottom line that says semaglutide. And, as time went on, 6 months, 12 months, 18 months, 24 months, you can see that there was the line for semaglutide is actually lower than the line for the placebo. And so less people in the semaglutide or Wegovy group actually developed cardiovascular disease compared to the placebo. And you could see that the lines really started separating early on. So that benefit, they actually started seeing around 6 months or even earlier. If you look, you can see the separation here, and it persisted on even to the end of the study. And so this was a really landmark seminal trial because we did not have any data before this, and people with obesity without diabetes, that this medication class can actually improve heart disease risk. And that was pretty cool. This was the study that actually led Medicare to cover Wegovy for people with obesity and established heart disease, stroke, and peripheral artery disease. And that was a really big game changer for our patients. Many of my patients that I see in my practice with heart disease benefit from the results of this study because now Medicare covers the medication. Let's talk a little bit about GLP-1 receptor agonist and heart failure. So I'm going to talk about 2 types of heart failure. There's heart failure with preserved ejection fraction, which is called HFpEF. And then there's heart failure with reduced ejection fraction, which is called HFrEF. So we think that GLP-1 receptor agonist medications can be beneficial in people with both types of heart failure. It could actually help improve that remember that fat that I was telling you about that sits around the heart that can be inflammatory. It could actually improve that amount of fat that sits around the heart. Maybe it could actually help reduce atrial size. It may help the heart work even or less harder, so that way the heart failure symptoms are improved. So a lot of these mechanisms behind, how GLP-1 receptor agonists improve heart failure symptoms are still being studied, but we do have data that especially in patients with heart failure with preserved ejection fraction, with or without diabetes, they had improvements in their exercise tolerance and their physical activity. And that's what these lines are really showing here. So there's this line right here, the red line is again, this isn't semaglutide, which is the same drug that I just talked about earlier in the SELECT trial. And this is in patients with and without diabetes. And you can see that in both studies, the semaglutide line is lower than the placebo line. And so they're having fewer events, fewer cardiovascular disease events. And they also had, or heart failure events, I should say, HFpEF events. And they also had improvements in their physical activity, their exercise tolerance. And I see this in clinic, by the way, also when I talk to patients, they're able to breathe a little bit better. They can actually hike, or they can do more physical activity. They don't get as tired and winded, and it's pretty cool. We also see the same improvements for patients with tirzepatide. So if you recall, tirzepatide is the generic name of the medications that bound in Mounjaro. And so this was a particular study that looked again at tirzepatide in patients with heart failure with preserved ejection fraction and obesity. And you can see again that the tirzepatide line is lower than the placebo line. So these individuals are having less death from cardiovascular causes or worsening heart failure symptoms in the tirzepatide group compared to placebo. And then I do just want to mention that many of our patients with heart failure with preserved ejection fraction also have sleep apnea. And there was a study that was published in 2024 that showed improvements in sleep apnea in patients that either used CPAP or did not use CPAP. Both types of patients saw improvement in their sleep apnea when they were on tirzepatide. And this trial was really pivotal because it led Medicare to approve tirzepatide for the treatment of sleep apnea in individuals with obesity. So we were able to get another treatment approved with this wonderful data to help our patients. I do want to briefly talk a little bit more about kind of understanding women's cardiovascular disease risk. So historically, in cardiovascular clinical trial, women have been underrepresented, so we don't really understand the sex-specific responses to treatment. We do know that obesity, again, increases the risk of developing heart disease in women, and that we need more data looking at GLP-1 receptor agonist in improvements in heart disease outcomes in women, because again, I think one of the things that people don't maybe understand, there are a lot of risk factors that women develop earlier in life that increase their risk of developing heart disease later on in life that we often don't think about. There are their traditional risk factors like smoking, high blood pressure, diabetes, high cholesterol, obesity, and more, family history, but there's actually women-specific risk factors, associated with PCOS and pregnancy, even certain things that might happen to their child when they're born can influence a mom's risk. So there's a lot of different factors that we have to think about. Also, menopause is a big part of that increased risk of developing heart disease down the line. So we just need more data and research. So a common question that I get is, well, how long do I need to be on these medications? And I say that, well, I wish I could rewire somebody's brain to help them not have the appetite dysregulation that they're experiencing, but I'm not able to do that, and neither are the medications. The medications are helping to level the playing field, but just like any other treatment for diabetes, heart disease, if you stop your medications, you're at risk of that condition getting worse. And we do have data for this as well. So we know that the majority of patients that actually stop medications in clinical trials will actually regain weight. So this is looking at semaglutide, and they're looking at weight loss maintenance. So what they did is they gave everybody in the group semaglutide for the first 20 weeks. And then at 20 weeks, they took half the participants off of semaglutide and switched them over to placebo. And you can see that here, this is change in waist circumference, but here you can see that the people that they took off semaglutide at week 20 actually regained weight. Now, they weren't back to where they started up here, but they did regain, about half the amount of weight, at least by 68 weeks. But those individuals that actually continued semaglutide, they actually continued to lose more weight. And this is the same that we see with tirzepatide. Again, the people that everyone started off on tirzepatide, and at week 36 in this study, they took off half the participants and put them on placebo. And you can see that these individuals regained about half of their weight by week 88. And same thing, increases in waist circumference. One thing I didn't talk about, I did show it on the graph, but as far as like how much weight individuals on average lose. So with semaglutide, which is Wegovy, people lose about, on average, 15% of their total body weight. With tirzepatide, which is Zepbound, it's closer to 20 to 22%. So let's talk a little bit about the future of weight management. So I'm hopeful that we are going to have more and more therapies that will be accessible to patients, that hopefully more insurance companies will cover. And that way we can get, more patients on these medications to help them improve their health. So in the pipeline, we do have several medications that are, I'll say they're cooking. And the good news about this is that some of these medications are actually pill options, which is very exciting because sometimes patients don't want to inject themselves with once a week. Maybe they have needle phobia. Maybe that's just not their jam. And so they, would rather take something by mouth. And we currently don't have anything that's a GLP-1 receptor agonist that works well for weight management. There is one called Ribelsis for the treatment of type 2 diabetes, but at the dose that we use it for diabetes, it doesn't really result in significant weight loss. And we don't prescribe that for weight management. It could help a little bit, but it's not a weight management medication. So we do have some oral options that are in clinical trials, and hopefully in the next year or two, we'll see some of these getting approved. There is another medication that actually, you know, is pretty exciting that's in clinical trials called retatrutide. This is also a once-a-week injectable medication. You know, before we had these once-a-week injectable medication classes, we weren't seeing weight loss in the 15 to 20 to 5% range on average. But once semaglutide and tirzepatide were approved, it was a very exciting time. It is a very exciting time, I should say. But in individuals that were in clinical trials on this retatrutide, again, this medication is not FDA approved yet, it's still in clinical trials. People are seeing upwards of 25 to 30% total body weight loss. So this is, I think when this gets approved, hopefully it will, it's really going to be like the next game changer as far as, you know, the injectable medications. Oh, one thing to kind of emphasize, so this is the average weight loss that people experience in clinical trials for obesity treatment. So you can see for the oral option, the pill option, it was about 15% all the way up to 25%. And this was the average weight loss that people experienced if they also had diabetes. So in people with diabetes, for kind of not clear reasons, even if you use the same dose of medication, let's say in somebody with diabetes compared to without, the person without diabetes is probably going to lose more weight. People with diabetes do tend to have less of a response to the medications, but it's still meaningful and it's obviously still worth pursuing because there's a lot of other potential benefits to these medications. It's, you know, again, not just about weight. It's not that they won't experience weight loss. They just may not have the most robust response compared to somebody else, but it's significant, you know, 10 to 15, 16, 17% of total body weight loss can really help improve outcomes. And that just kind of speaks to don't compare your journey to anyone else's. So I'm going to run through these common myths about just keeping an eye on the time about medications to treat obesity. So number one, why are we using a diabetes drug for weight loss? First off, you know, I hope by the end of this presentation, you understand that, you know, these medications are not just weight loss medications or diabetes medications. These are cardiometabolic medications, and they can improve a lot of different health outcomes, including cardiovascular health outcomes. Isn't taking medications to treat obesity the easy way out? And I'm going to say no, because remember, that implies that everything about our weight is in our control when we know it's not. We have this biology, we have these genetic factors, these environmental factors. And medications are a tool in the toolbox in addition to lifestyle changes, getting the other appropriate medical care that you need. If I stop medication, won't I regain weight? What's the point of starting it in the first place? And again, I hope people understand that this is a chronic disease, just like having diabetes and heart disease. And we really have to think about this as a marathon, not a sprint. It's not just about starting medications for 6 months, stopping them, and then hoping, you know, everything will be fine. Yes, will there be potentially a subset of people, a small subset of people that could maintain their weight for some period of time off medications? Probably. But for most people, that's not going to be the case. I do want to address the compounded versions of these medications. So compounded semaglutide or tirzepatide are not FDA approved. I do not prescribe them to my patients, nor do I recommend them to my patients, because at the end of the day, I just don't know what's in them. I can't really vouch for their safety or if they're actually a one-to-one equivalent. The FDA is cracking down on compounding pharmacies right now. So I think compounding is definitely going to see its end at some point, hopefully soon. And then can I eat anything I want while I take medications to treat obesity? And remember, going back to what I was saying, it's about improving body composition. We want to make sure we're eating lean protein, the fruits, the vegetables. So, you know, it's not, I hate when people are like, oh, it's a free-for-all. You can just eat all the candy you want. And it's like, no, we still want to focus on what we're eating, because at the end of the day, this is about improving your long-term health. So key takeaways, I want people to understand that obesity is a multifactorial chronic disease that's shaped by our genetics and environmental factors. Really keying in on that body composition and understanding improvements in body composition is a big goal of therapy for my patients. The latest obesity treatments also offer significant benefits for our heart health. And we want to prioritize people first language when we talk about the chronic disease of obesity. So thanks for listening. If you have questions, that's how you can get a hold of me. But I will open it up for questions right now.
Awesome. Thanks so much, Dr. Patel. That was such an informative presentation. I will go ahead and get into the Q&A here. A lot of these questions were answered throughout the presentation.
Yeah.
I'll try to just sort of, prioritize the ones that maybe weren't answered in the presentation.
Okay.
First, do you know on average how much weight is typically regained either naturally versus, or I guess naturally versus after being on a GLP-1 agonist medication?
So I'm assuming if this participant asking if somebody stops the GLP-1?
I think so, yes.
Yeah, that's a good question. I don't think that's ever been studied. I would say that in my experience with patients that have lost weight in the past with lifestyle factors and then regained, they almost always regain most of it back. With GLP-1 receptor agonist class, I have yet to take somebody off of it because they were like really adamant that they wanted to come off of it. Sometimes those conversations come up in the beginning and I'm very clear, I set I'm honest and open with my patients and I'm like, look, I'm a partner in your care, but I just want to be very transparent with you that, these are not medications we just start for 6 months or a year. And if for some reason you have to go off of it or you want to go off of it, like, please let's do it under medical supervision so that we can intervene if you're experiencing weight regain, and we can monitor your body composition. So I think that the weight regain is probably a bit slower with after medications, but could depend on a lot of things, right? Like if somebody has an injury or like a stressor in their life, they may experience weight gain more rapidly. So in the controlled trial, you could see that at least well, with tirzepatide, for example, about it from week 36 to week 88, which is 52 weeks a year, they regained about 10% of their body weight at that point. But you could see that the slope was still going up. So if we extended the study out maybe to 2 years, 3 years, they might get closer to that initial starting point.
Right. Okay. Got it. Thank you. That makes sense. Next, I take Ozempic to control blood sugar and weight. It no longer curbs my hunger. Is it still worth taking for protection against Alzheimer's, heart disease, high blood sugar, and inflammation?
Yeah, so we know that there are other effects of the medication class aside from weight, and improvements in appetite. I think it's important to talk to your doctor and see if there's another medication you could potentially switch to that could help. Sometimes when patients, for example, are on Ozempic, we may switch to Mounjaro, if their insurance covers it and they're able to get it, to see if that works better for them. It is like that's a very like individualized discussion. So there are, but just to emphasize, there are non-weight benefits that can be had from this medication class.
Great. Thank you. Next, semaglutide versus tirzepatide. What are the benefits and risks from a cardiovascular, diabetes, and weight loss perspective?
We just have more data on semaglutide, especially with diabetes. It's been around longer. It was first approved for the treatment of diabetes in 2017, and tirzepatide was 2022. I have to go. Yeah, it's the last couple of years. So we're still getting more data with tirzepatide, but both by all means are excellent tools for weight management and diabetes. The cardiovascular disease outcome trials with tirzepatide are still ongoing, and I think it's still going to take a few years, but I imagine that they are going to show benefit, just like that SELECT trial that we were talking about earlier. So both great tools. We just don't have as much data on tirzepatide as semaglutide because it's newer.
Great, thank you. We have a question here in the chat. I'm just going to hop over. Can you discuss some potential side effects with these medications?
Yes, absolutely. So the side effects with the medications are actually, they're real, right? They're not like, they can happen. Most commonly, it's GI side effects. So individuals can experience nausea, constipation. Some patients may develop really severe side effects, which include vomiting, which I always tell patients, I don't want you vomiting. If you're vomiting, you got to tell me. Diarrhea, abdominal pain. There's other side effects, that could happen, headache. This is why it's really important to work with somebody experienced, because titrating the dose to your tolerance is very important. And sometimes, especially in my patients with heart disease, patients with LVADs, like patients transplant, post-transplant, like, patients that are undergoing cancer treatment, we do not want to just prescribe medications without supervision and monitoring. And sometimes we have to stop intermittently, and that's okay. I would say the majority of patients with careful dose titration, kind of working through some of those dietary challenges that might be contributing to the side effects, and really helping them slowly up titrate the medication as tolerated, it helps them overall. And over time, like for example, if somebody experiences nausea, it does tend to get better, but there are some people that it's just too severe. And, at the end of the day, that's just not the medication for them. And we have to try to figure out other alternatives that can work.
Great, thank you. We have one follow-up question to that one. Can these drugs cause gastroparesis?
Yeah, that's a good question. So there is not strong data that they cause gastroparesis. We use them in caution with people with gastroparesis because they already have slowing of their GI system or their stomach emptying, and these medications also do that. That's an intentional effect because it helps with blood sugar control and may help with improving fullness. But again, weight management wise, they are working in the brain. It's not these other effects like that are leading to the weight loss by itself. So in people with I always ask, especially a patient with diabetes, have you ever been diagnosed with gastroparesis? If so, how severe is it? Do you have symptoms every day? Like, are you nauseated all the time? Like, do you have, other symptoms? Like, do you vomit? And so in those cases, maybe this isn't the right class of medications to start right now. We do know that especially in patients with diabetes, if you can improve their blood sugar control, that their gastroparesis might get better. So sometimes these medications kind of counterintuitively can be used, but you have to balance it with like, are they going to get worsening side effects, or are they going to not tolerate the medication? So have I used them in patients with gastroparesis? Yes, it's pretty mild in their case. They're not having like daily symptoms. Maybe it was pretty bad, when they first got diagnosed with diabetes because their diabetes was out of control. Now it's better. But those are all really important things to consider, which is, again, going back to what I said, you don't want to get this off the internet from some random person with a prescription pad. You want to get it from a doctor that understands the side effects and risk and benefits and can actually help you work through those.
Absolutely, yeah, thank you. I'm just jumping down to another sort of related question to the GI and digestion. Do these medications change the way food is digested beyond just slowing digestion?
Not that I'm aware of, except I do think that, and this is not proven in humans. I think this is from animal studies. I do think that it decreases the tolerance for higher fat containing foods, potentially by impacting the digestive enzyme that digests fat. I'm not sure if that's really happening in humans. It's been kind of shown in other like non-human studies. But going back to what I was saying, that people don't tolerate high fat, greasy containing foods. And I do think that there is probably some alteration in digesting fat or that particular types of food that contributes to that. So, but I'm not aware of like changing absorption of nutrients, or, you are eating fewer calories, so you are absorbing fewer calories compared to what you were eating before the medication. But yeah, I'm not aware of any other changes. I would say that if anyone has a GI condition, whatever it may be, really helping understand like what your condition is, what the symptoms are. Sometimes I reach out to people's GI specialists to be like, hey, are you, how bad is this person's like Crohn's disease or IBD, or how bad is this condition? Like, can we, can we start a medication and closely monitor?
Got it. Great. Next question, would these weight loss medications be appropriate for older adults, such as someone who is 78 years old?
Yeah, good question. I don't think we have a lot of data from primary trials in older adults. I have to go back and look and see exactly like what the age cutoff was, but we just don't have a lot of data for older adults. However, there have been studies that have looked at kind of observational data and safety in older adults. And generally, the GLP-1 receptor class of medications are considered probably the safest to use compared to some of the other ones, those pill medications that we talk about. I use them in patients that are in their 70s or even 80s. And it's with understanding that if you have other medical conditions, again, we need to monitor you closely. If you have heart failure, I don't want you vomiting, on diuretics, getting dehydrated. It's just, we got to keep those things in mind. So those are people that we see a little bit more frequently. Make sure that they have a two-way line of communication to get a hold of us. I sit in the same department as the heart failure specialist and the kidney doctors and the liver doctors here. And so if there is a problem with any of our patients, I can get up and literally walk down the hallway and say, hey, this person, for example, has lost a lot of weight and their blood pressure is lower, which is great, but we have to, maybe work, do you mind seeing them because they may need to adjust their heart disease meds now.
Wow, that's awesome. Yeah. Okay, let's see. This one, unrelated, but quickly, I just wanted to address this one. What is the process of engaging in the services of your clinic? So I guess like establishing care, are you accepting new patients? Can you speak to that at all?
Yeah, we are accepting new patients. It does require, the department requires a referral from a primary care. If you have a cardiologist in this department or the liver doctor or kidney doctor, they know exactly how to put those referrals in. But if you're not a part of the advanced organ therapies department here at CPMC, you can get a referral from your primary care and fax it over to our office, and have them fax it over to our office. Yeah.
Okay, awesome. Thank you. Do you know of any quality at-home scales that provide information beyond just your weight in pounds?
Though there are scales out there that measure body composition, but I don't really know how accurate they are, to be honest with you. So I just usually have patients have a normal scale that they can track their weight, and then have them come in and do the body composition on my machine.
Okay, great. Thank you. Next question, do weight loss medications help with kidney disease?
Great question. So we actually do have data that in patients with type 2 diabetes, using semaglutide under the brand name Ozempic at 1 milligram a week reduced the risk of progressing to end-stage renal failure with people that had kidney disease, diabetes, which is awesome. We don't have that data yet for tirzepatide. There is a trial ongoing for people without diabetes, with obesity, and looking at improvements in kidney outcomes. We think that it could help with proteinuria in people that don't have diabetes. I think that there's some data from some of the trials that show that, but more to come.
That's awesome. Thank you. Let's see here. Oh, this was a good one. If the heart is a muscle, is it possible to lose heart tissue on these medications, similar to how other muscle mass is lost?
Great question. So the heart is, yes, muscle. And you asked a very good question. There was recently a study that was published that looked at the tirzepatide in patients with heart failure with preserved ejection fraction. So individuals with HFpEF usually have thickening of their left ventricle walls, so they have a little bit more muscle or mass there. And they did see in that study, they used imaging and looked and tried to quantify how much, with the weight loss, how much fat loss around the heart they had, and also how much muscle loss they had. And there was some muscle loss. Do we think it's, do we think that it's potentially harmful? I don't think so. I think it actually helped improve the functioning of that person's heart. And all the data that we have shows improvements in cardiovascular disease risk. So even if somebody is losing a little bit per se, it's not like causing them negative health outcomes. We're seeing benefits from it. Now we don't have other studies. I can't tell you like how much is somebody losing or what it is. That was the only study that I could see recently published. But I think that That's a very good question, because we do talk about muscle mass loss, and we're always like, you got to keep your skeletal muscle. You got to keep your skeletal muscle. But like, what does that mean for your heart? We just know that there's improvements in outcomes for cardiovascular disease with these medications, even if there is alterations in, especially the fat around the heart, which is probably a good thing because you're reducing that visceral fat or changes in the structure of the heart potentially.
That's awesome. Thank you. I have one quick question. I know we're at time. I thought this might be a helpful one to answer, though. Could you repeat the oral medication that you mentioned you prescribe in combination with Zepbound when results are slow?
Yeah, there's combinations of different things that we use. These are off-label and generic. So sometimes I'll use Topamax, sometimes we'll use Wellbutrin. Sometimes we'll use medications like phentermine. This is not, and again, I want to caveat that like we have to look at your individual like medical history. If somebody has very strong heart disease or like high risk factors for arrhythmias and all of that, many of these medications we do not use. So it just depends. Like I would never use phentermine in somebody with like established heart disease or, but these are all tools that we use still on top of medications like Zepbound or Wegovy.
Great. Thanks for clarifying that. And I know we have a few more questions that we didn't have time to answer. Dr. Patel kindly listed her email in the chat, so please feel free to direct questions there if your question wasn't answered. And just wanted to thank everyone again for joining today's presentation hosted by the Kanbar Cardiac Care Center. A special thank you to Dr. Patel for taking the time out of your busy schedule to present and share your expertise on such an important topic. The Kanbar Cardiac Care Center remains committed to providing community education on cardiac health and will continue to host presentations every other month. Please keep an eye out for emails sent out about upcoming presentations. Thanks everyone again, and I hope you all have a great evening.
Take care.